it's a fairly young university founded in the 1960s. It does have 3 Nobel laureates, and this person here, he's actually a founder of the MRI. I think we are celebrating some anniversary this year. And those of you may recognize, especially those from China, he's a physicist who helped China to develop the atomic bomb, and he was physics professor at Long Island. Anyway, so we're going to talk about preoperative beverage and the MPO status, and then we're going to talk about different type of IV fluids and goal-directed fluid therapy. Previous speaker had touched a little bit. Just want to show you some recent data. And lastly, this debate about restrictive versus liberal fluid regimen, and just want to share with you the most recent data on Relief trial, and those of you who followed this trial, this is the one conducted by Paul Miles and his group in Australia. So let's take a look at, first of all, preoperative fasting. Now, maybe by a show of hands, any of you in the audience give patient fluid up to 2 hours before surgery? Wow, that is pretty amazing. You guys are way ahead of most of the hospitals in the US, I can tell you that. So this notion about starving for 8 hours, starving from midnight, is something that we have always been doing, and a lot of hospitals, I think, still do that. But with the enhanced recovery, we try to encourage patients to drink. And I'll talk a little bit more on Saturday morning. But this notion about giving patient fluid up to 2 hours before surgery is still not very widely practiced. And if you think about it, it's really dogma, and patients, physicians are worried that they may throw up, they may aspirate. And if you look into the evidence, really, the evidence is not really there if you give clear fluids. No coffee with creams, no orange with pulps, but clear fluids is really very little risk. In fact, the American Society of Anesthesiologists guideline actually stated that you can take clear fluid up to 2 hours before elective procedures. And we wrote an editorial questioning that why people still don't give fluids, clear fluids up to 2 hours before surgery. And beyond that, this concept about preoperative carbohydrate drink, which is a little bit more a recent concept. And the notion of giving, instead of clear fluids, giving some carbohydrate drink is that we know that we typically don't do well if we starve, right? Now, many of you may run a marathon or go for a swim meet. How many of you actually starve for 8 hours before you go and run a marathon? It's silly, right? I mean, nobody does that. But yet, if you think about it, patient having surgery, in terms of physiological challenge, is probably as robust or as severe as running a marathon, if not more, and yet we let our patients starve for 8 hours. So it doesn't really make sense. And also, those of you who run marathon and who have kids participating in major sporting events, and I have 2 daughters that swim, and I remember that a week before their major meet, their coach would tell them, feed them with lots of carbohydrates, right? And they consume pasta like nobody has ever consumed. And that is because they want to build up a energy carbohydrate store, and that is this notion about a patient is about to undergo a major physiological challenge. You want them to build up some carbohydrates so that they are not in that anaerobic conditions. So that is the basis of giving pre-op carbohydrate drink. And in fact, there is evidence to suggest that if you're given pre-op carbohydrate drink, they manage their glucose better. A concept known as reducing insulin resistance. So the pancreas actually works better, and there is instead of catabolic metabolism, they have more anabolic metabolism to preserve the lean body mass. And there's been evidence showing that if you give pre-op carbohydrate drink, not only from a comfort perspective, but also, in fact, reduce insulin resistance and therefore better perioperative glucose control, and along with some of the other benefits listed here, less PONV. You know, just be humane and kind and feed patients. Fluid management, as I said, it's something that we tend to think about. Well, it doesn't really matter. You can just give whatever fluid that you need, right? So this is a survey of 2 major medical centers in the US. And they looked at their electronic database and looked at how much fluid did the patient get. And what they found is that in those days, they didn't have really any guidelines in terms of how much they should give. So they found that there was quite enormous variations of how much fluid the patient get. And these are all similar procedures. And you can see here the range from 2 mils per kilo per hour to 14 mils per kilo per hour. So a 7-fold difference within the same type of surgery. So a typical 75 kilogram patient who are undergoing a 4-hour procedure, minimal blood loss, they could receive in one patient 700 mils, in another patient 5,400 mils of crystalloid during surgery. And this is the different type of surgeries listed down here, from prostatectomy to pancreatectomy, hysterectomy. And again, these are 2 institutions, University of California, Irvine and Vanderbilt University. And again, you can see that range is enormous. Now, you would think that some of the factors that may affect that could be, you know, maybe hemodynamics. Patient's blood pressure is low, you give them some fluid. Patient's urine output is low, and you give them more fluid, right? Or the surgery is long, and your uncooperative surgeon is losing blood on the other end. You got to give fluid replacement. So those are the sort of factors we think that would have determined how much fluid the patient get. But in fact, the main factor that why these patients get such a big range is the anesthesia provider. So it depends on who you get, right? If you get Dr. Thomas one day, you may get 700 mils. And if you get another anesthesia, you get 5,400 mils. Think about that, right? And again, this is something that when you are in the room at a surgery, you know, when the bag goes empty, what do? You take the bags down and you put another bag up, and then when the bag's empty again, and you replace it until the end of surgery. So we don't really have a objective or strategy in mind when we give fluid. Now, many of you are familiar with this U-shaped curve in terms of how much fluid you should give, right? Again, the principle is that you don't want to give too much, you don't want to give too little, because on both ends are not associated with bad outcome. In particular, the gastrointestinal tract is very sensitive to fluid or the amount of crystalloid. Too little is bad, too much is also bad. Now, although this is a theoretical concept about, you know, not giving too much and too little, in fact, if you look at in real life, it actually translates into reality. So this is a study from Boston where they divided the amount of fluid that they get into quintiles, so 20%, the next 20%, all the way up to the top 20%. And again, you can see that of the various outcomes, you can get this U-shaped, feel of this U-shaped curve. Either is mortality, complication, and again, this is respiratory complication. If you give too much, they have higher respiratory complication rate, acute kidney injury, length of stay. So it does actually pan out that, you know, giving too much or too little is associated with bad outcome. I think my computer has done the same as they did to you. I guess you can't see either. That's it. I think you need some resuscitation. Maybe you can give some bolus of fluid. We need SV or SVV. What do you think? We need, or maybe passive leg raising.
Tak, sebab dia cakap kan bila dia tengok dia curve ni dia kan.
All right, let's go back to where we were.
Dia akan cakap pasal Glycocalyx.
And this concept about the endothelium that you all studied in physiology, and in fact more recently it is found that there is this layer, something called the Glycocalyx, which is what we traditionally known as sort of endothelium. And in fact there is a layer of proteins lining this endothelium, as you can see here at the top panel here. And these are sort of nice looking grass, just like your nice garden lawn. And then what happens if you give too much fluid, it becomes that. Okay, look at that, totally all the Glycocalyx is gone. So in fact that's why how fluid leaks out of the capillaries, and I think it does that again, and therefore it can potentially cause edema. I think we need resuscitation again. Maybe it's telling us it's too late in the afternoon.
Bila Glycocalyx dia destroy, so dia blood vessel tu jadi not reactive, dia vasopressure, so dia permeability increases.
Maybe you should stand back next to me so that All right. So hypervolemia drives up the hydrostatic pressure and damages the Glycocalyx. So what does that mean? Well, this is what it means, right? This is the sort of patient that you see at the end of a long case where you give like 12 liters of fluid, and then she looks like a Michelin Man, and then you've got to say, okay, I guess I can't extubate these patients. Where do you send them to? You send them to ICU so that they can stay there for a couple of days to pee out all the fluids. So this is actually something you can avoid, right? And in the context of enhanced recovery, hopefully this is not something that you see on a regular basis. So there are a number of devices you can use, as previous speaker alluded to, that to trying to determine this goal-directed concept of administration of fluid. And I'll show you some studies that looking at difference in goal-directed fluid therapy. Now in terms of fluid, now we know that colloid and crystalloid, and again that controversy continue to rage. In terms of physical characteristic, clearly colloid is a larger molecule, it retains in the intravascular space longer compared to crystalloid. This study shows that between colloids such as Valdeven and pseudocolloids, I call it gelafusin and saline, you can see that the difference in terms of how long they stay within the vascular space, and you'll be amazed that crystalloid actually get out of intravascular space pretty quickly. Within about an hour, most of the 80% are gone, and most of it gone into the extracellular fluid compartment. That's where you see that previous phase of the patient. But the question is that, it's a bit more difficult to determine when you give colloid and crystalloid what the actual impact to the patients. And then beyond another controversy is what the content of the solutions. Within crystalloid there is the saline, which is 0.9% sodium chloride, and then there is a more balanced crystalloid. Is there any difference where you give saline versus a balanced versus a non-balanced crystalloid? So there is evidence suggesting that this retrospective review of cases where they compare saline versus plasmaline, which is a balanced crystalloid, and show that there is actually a difference in hospital mortality and complication rate. And when they looked at a bit more details, again, the idea is that saline tend to result in hyperchloremic acidosis, and therefore you tend to do more ABGs, arterial blood gases, you tend to have more lactic acidosis. In fact, instead of dialysis goes up, blood transfusion goes up. So there appear to be differences between the different type of crystalloid. This study shows that if you give a more chloride-based solution, your risk of renal injury goes up. This is using the right flow criteria. This is the intervention period where they use more balanced solution, and compared to just using saline, it seems to reduce that incidence of renal injury. Now, about colloid, crystalloid, about what is the harm of starches. Some of these are a bit more historical now, that many of you will remember that the 3 big trials, the VSEP trial, the 6S trial from Scandinavia, and then the CHEST study from Australia, implicating harm from starch, giving starch at least in the ICU population. So these 3 trials were all done in the ICU population. Again, this sort of led to the significant reduction in use of starches in the ICU, and also carry over in the operating room. But if you look at data, the perioperative renal injury story with starch is certainly not the same as what you see in the ICU. For example, this study, a meta-analysis here, looking at 2,000 patients that received tetrastarch, so these are the Voluvan and Volulite, and show that there is no difference in mortality, there is not statistically significant, there is no difference in renal injury, there was a difference in reduction in transfusion. So in the perioperative setting, it is not clear-cut. It has not been shown similar to the ICU study where there is increase in renal injury. But nevertheless, the use of starch has really certainly reduced significantly in the perioperative period. And another study, meta-analysis, showed that, as I said, that the understanding is that starch seems to be associated with nephrotoxicity in the critically ill patients. But in this meta-analysis, they did not find any difference in terms of increasing the risk of renal injury with the use of tetrastarch, the 130.4 starches. This is a compare colloid and crystalloid in a C-section trial, and basically is a prospective multi-center trial in 167 pregnant women undergoing C-section of the spinal. Patients were given either 500 mils of tetrastarch, 500 mils of Ringer's lactate versus 1,000 mils of Ringer's lactate, and the primary outcome is to see which solutions reduce the incidence of maternal hypotension that was defined as systolic pressure of less than 80 millimeters of mercury. And essentially, they found that if you give colloid, you tend to have a lower incidence of hypotension compared to giving crystalloid, based on the physical characteristic that I shared with you earlier. Now, the previous speaker talked about goal-directed fluid therapy has been really, goal-directed therapy has been practiced for probably over 20-25 years. This is a study that we did many years ago, showed an improvement in outcome. And again, if you look at in those days, we tend to give a lot more fluids. If you look at the crystalloid, even in the control, in a protocol group, was still 13 mils per kilo per hour. So that is way more than what we typically give today. But in that context, we are able to show a reduction in length of stay and earlier return to bowel function. More recently, this is the trial that was from the UK, and again, the hypothesis is to see whether goal-directed fluid therapy in high-risk population reduce post-operative complications as the primary outcome. And again, this is probably one of those clinical trial, as an investigator, this is probably one of those nightmares that you don't really want to face because your study is not quite adequately powered, right? Your P is like 0.07, and we wish that you enroll another 100 patients, but nevertheless, that was what the result was. There was a trend of reducing complication, but not quite statistically significant. But as you can see here, certainly if you are a patient, no doubt that you want to be probably in that group versus the usual care group, even though it's not statistically significant. But so that is where the current knowledge is, and when they did a meta-analysis overall, they show goal-directed fluid therapy was associated with better outcome. So what about in the context of enhanced recovery? As you know, with enhanced recovery, the amount of fluid we give tend to be less, and there are also other elements that we introduce in enhanced recovery. So this meta-analysis by Dilip Logo from UK actually split out those goal-directed fluid therapy without enhanced recovery versus those with enhanced recovery. And again, they still see some advantages, even in enhanced recovery, in terms of ICU stay, to use goal-directed fluid therapy. Now, I want to spend a few minutes just to show you this most recent fluid study. It's called a RELIEF study, or restrictive versus liberal fluid therapy for major abdominal surgery, that was published this year in New England Journal of Medicine. This is from the Australian Trials Group, led by Paul Miles. And basically, it is looking at this restrictive versus liberal, however you define it, right? So 3,000 patients undergoing major abdominal surgery, and they looked at patient up to 2 hours, 24 hours after surgery, and the primary outcome is disease-free survival at 1 year. Secondary outcome, acute kidney injury at 30 days. The renal replacement therapy or dialysis at 90 days, complication and death. And on average, the amount of fluid given in the two groups is, one group is about 3.7 liters, the other group is about 6.1 liters. So one group is double the amount of the other. So this is mainly, there's a combination of colloid and crystalloid. So let me show you the demographics of these two groups. So restrictive group, liberal group, and the median fluid administration, crystalloid is about 1,700. Liberal group is about 3,000, colloid is about the same. And if you look at, say, 24 hours, total accumulated fluid, 3,600 crystalloid in the restricted group, 6 liters in the liberal group for total amount of fluid. And within 24 hours, it's about 3 liters and 6 liters. So what did they find? Well, the mortality is absolutely no different. They follow up the patient up to a year. As you can see, the two lines overlap each other between the liberal and the restrictive group. Now, interestingly, when they looked at some of the secondary outcomes, and particularly surgical site infection, interestingly, the liberal group actually fared better with lower incidence of surgical site infection. And again, this is statistically significant because the number is obviously pretty large. And also, acute kidney injury was statistically significantly lower in the liberal groups compared to the restrictive group, and the renal replacement therapy just under 0.05. There is no difference in mortality at 0.06 p-value. So the conclusion of the trial was that if you give the patients about 6 liters versus 3 liters, no difference in mortality, but they may do better in terms of renal outcome and infection rate. Now, another study that is more recently published under context of enhanced recovery, again, using goal-directed fluid therapy, and the study essentially found no difference between using colloid and balanced crystalloid in the context of goal-directed fluid therapy. I think part of it could be explained by this graph, that traditionally, we tend to keep patients dry because we starve them for hours, and therefore you sort of start off with fairly negative balance. And then if you give fluids, then they becomes more positive, and therefore you see a better outcome. Whereas now, with enhanced recovery, you don't starve them as long, and because you give patients fluid up to 2 hours, and therefore they don't start in that severely negative terrain, and therefore you may not see as much benefit in a typical surgery with very little blood loss. So I think that could be explained that why in enhanced recovery you don't see as much benefit in terms of hemodynamic optimization or goal-directed fluid therapy. So the last few slides, I just want to share with you what is coming. Again, there's no data. This is just telling you what trials are currently ongoing. So there are two big trials that is going on, Optimize 2 by the same investigator from the one I presented earlier. Is a fairly pragmatic randomized trial, 2,500 bowel surgery patients, 50 centers in six countries. And again, to determine whether goal-directed fluid therapy with a low-dose inotrope is better than usual care in GI surgery. Again, trial is still ongoing. There is no data to report probably for another year or so. And then there is another trial called the Florilla trial. This is called Fluid Optimization Emergency Laparotomy, open label to a multi-center randomized control trial. And again, the hypothesis is to see whether hemodynamic therapy during and after bowel surgery could save life when compared with usual care. 100 UK hospital, 8,000 patients, primary outcome 90 days mortality. Secondary outcome, a whole bunch of other things, 1 year mortality, length of stay, hospital admission. Again, this is still recruiting, but we should see the results of these two large studies in the next couple of years or so. Lastly, just wanted to share with you, given all this data that I just showed you, how should I go back to my hospital and practice? I think, this consensus guideline that was published in Preoperative Medicine, and those of you who are interested, you can go to the POQI website. It's POQI, Perioperative Quality Initiative, POQI.org. If you go to that POQI.org, you can get all this article for free. And basically what it does is that we recommend that using goal-directed fluid therapy is likely to be safe, and for patients undergoing major surgery, it has little risk. The use of advanced hemodynamic monitoring may enhance clinical decision making, but it may not necessarily to increase post-op care. Now, I got one more slide where I'm not going to ask our friend to come up again, but I just want to tell you that what I typically manage is that for those patients who are high risk, then I consider giving consider goal-directed fluid therapy. And for those patients who are moderate risk, you have to, thank you. So this is the diagram. So if you look at here, you've got to look at patient's risk and procedure risk, right? If both patient low risk and very small procedure, then standard monitoring I think would be fine. If you have high risk procedure or high risk patient, perhaps giving some advanced hemodynamic monitoring would be helpful. So this is how I look at the patients, look at their surgery they are undergoing, then decide what would be the best monitoring management for that patient. Lastly, just want to share with you, this is a one-day meeting that I'm organizing the day before American Society of Anesthesiologists meeting, ASA, in San Francisco this year, beautiful city. October 12th, we want to come and spend a day of enhanced recovery program. Henry Kellett is going to come and speak along with many other speakers. Thank you very much for your attention.
Thank you, Professor Dr. PJ Guy. I'd like to invite all speakers to come to the stage and to receive questions from the members